Dear students and colleagues, we will talk today about acute dyspnea because it's a common and it's a broad spectrum of unpleasant sensation related to breathing, including air hunger, the sensation which can be elicited by prolonging a breath hold, sense of work effort, or chest tightness. Dyspnea can vary in intensity and quality depending on the underlying pathophysiological mechanism, and its perception is influenced by the patient's social, cultural, and psychological characteristics. Acute dyspnea is one of the main reasons for admission to the emergency department, as it's a common inherited disease and it can present in different situations and disease, including cardiovascular, infective, neurological, gastroenterological, and others. In pathophysiological mechanism of dyspnea, we can and know that present hypercapnia and hypoxia. It means that increase of arterial pressure of carbon dioxide by itself, which can lead to shortness of breath. An acute increasing of carbon dioxide, which potentially contributing to dyspnea, is a common occurrence in many diseases, including acute respiratory distress syndrome, COPD, asthma during exacerbation, and acute heart failure. In addition, acute hypoxia can induce air hunger, but the decrease of arterial pressure of oxygen necessary to trigger an unpleasant respiratory sensation is much bigger than the 4 millimeter increase of carbon dioxide required to elicit the same effect, at least in healthy subjects. When ventilation is constrained, healthy subjects perceive air hunger only when carbon dioxide falls below 6 millimeter. The second important mechanism for acute dyspnea is mechanical loading. It's a sense of increased work or of bracing or effort can be evoked in a variety of situations in which the elastic or resistive load against which the respiratory muscles contract increases, or in which the ability of the respiratory muscle to generate pressure is impaired. A decrease in respiratory muscle performance may arise both because of the weakness of the respiratory muscle or because the respiratory muscle have to contract in a situation of mechanical disadvantage due to a change of their operating less, as in presence of static or dynamic hyperinflation. The third mechanism, pathophysiological of acute dyspnea, is activation of pulmonary receptors. It can be indirect. Evidence suggests that information carried by vagal fibers play a role in genesis of dyspnea perceived in pathological conditions, characterized by pulmonary congestion, local mediator release, or parenchymal alteration. In pulmonary fibrosis, vagal afferents activation secondary to alveolitis has been proposed as a mechanism contributing to dyspnea. Particular attention should be paid to rapid onset dyspnea of unknown origin, as it's common in pulmonary embolism, where it can be the only symptom at rest or during exertion, and it often appears disproportional to the level of blood gases alteration. Interestingly, activation of irritant receptor in asthma has been the specific sensation of chest tightness or constriction, and often can be in patient with acute dyspnea. For diagnosing and diagnostic evaluation in patient who has dyspnea in emergency department, we have several group of tests. Of course, it's a very important is a clinical manifestation, clinical evaluation, when we can control respiratory rate of patient, when we have signs of respiratory distress as a tachypnea, hyperpnea, rapid shallow breathing, activation of accessory muscle during breathing. Plus, we can have a signs of increased work of breathing as a recession of suprasternal fossa, tracheal tag, Hua sign, sternomastoid activation, occipital dorsiflexion, nasal flaring, mouth opening, inspiratory laryngeal groans. It's the main ones. About the group of blood biomarkers we can control in patient with acute dyspnea, it can be arterial blood gas analysis like pH, partial pressure of oxygen, CO2, bicarbonate. We can measure the level of brain natriuretic or pro-brain natriuretic peptide. We can measure in patient high sensitivity cardiac troponin with a 12 leads ECG and level of D-dimers, which can elevate in patient with a pulmonary embolism, for example. And of course, it's imaging test as an ultrasonography of heart, lung, diaphragm. We can do chest X-ray, chest computer tomography with or without contrast. For evaluation acute dyspnea, we should control blood biomarkers is arterial blood gas analysis, and we can see evaluation acute changes in blood pH, partial pressure of oxygen, carbon dioxide. Brain B-type natriuretic peptide recommend for initial diagnosing patient for differentiation cardiac and pulmonary causes of acute dyspnea in conjunction with other clinical and instrumental data. Elevate pro-BNP level can further a congestive heart failure diagnosis. Troponins and creatine kinase for diagnosing acute coronary syndrome. D-dimers, I told that first of all for diagnosing pulmonary embolism, it's a degradation product of cross-link fibrin and increases in plasma following acute thrombus formation because of simultaneous activation of coagulation and fibrinolysis. However, some diseases like cancer, inflammation, they have elevated level of D-dimers, not just pulmonary embolism. It means that we should summarize all data of examination patient, not just one D-dimers. About imaging test, of course, ECG, we should exclude myocardial infarction, STEMI, non-STEMI, because it can be accompanied with acute dyspnea. We can use echocardiography to see cardiac function, valvular function, dysfunction. Chest radiography for suspected cardiac origin. In this case, we can visualize pulmonary venous congestion with upper lung zone flow redistribution or interstitial or alveolar edema manifesting as a peribronchial coughing. We can visualize septal lines, so-called curly B lines, air space, opacification with a basin distribution, cardiomegaly, bilateral pleural effusion as an indicator of primary cardiac related dyspnea, can indicate pericardial effusion, calcification, air, If we suspect pulmonary origin of acute dyspnea, it can be pneumothorax, pleural effusion, infiltrate, subcutaneous emphysema, pneumovidastenum in these methods of examination. The next methods we can use is coronary CT angiography. It demonstrates ability to rule out acute coronary syndrome and exclude clinically significant coronary artery disease in patients with non-STEMI. Spirometry, it's another method for the differential diagnosis of acute dyspnea, can indicate the presence of respiratory muscle weakness from muscular or neurological abnormalities, either an obstructive pathology such as asthma, COPD, physical airway obstruction, restrictive disease process, interstitial lung diseases, and normal spirometry indicate a need to evaluate for hypoxia as a source of dyspnea in patient. Here, this slide I show you different diseases and abnormal situation when we can visualize very good, clear in ultrasonography. I wanna to tell that this ultrasonography of lungs, heart, diaphragm, pleura is a very informative, very cheap screening test, and we can control for initial diagnosis, for during treatment, effectiveness of treatment, we can control with these methods, and really it's very effective and very informative. And you can see here normal findings in the upper part of this slide. We can see in patient during ultrasonography lungs, it's lung sliding, A lines, vertical lines less than 3 per scan. But if you can see at right, pneumothorax, absent of line sliding, absent of vertical lines, absent of line pulse in patient, in M mode, absent of light sliding. In case of lung consolidation, tissue-like ecotextura, so-called hepatization, the structure of lungs becomes as a lever. It can be imaged corresponding to a bronchograms, hyperechoic punctiform. In case of pleural effusion, anechoic fluid above the diaphragm, atelectatic line moving during respiratory maneuvers. Complicated pleural effusion with echogenic fluid and septations. We can see sonographic interstitial syndromes at left side, pulmonary edema when we visualize more than 3 vertical lines, so-called B lines between 2 ribs in a single scan, or inflammation, fibrosis, its vertical artifacts associated with the pleural irregularities or small subpleural consolidations, or lung confusion, it's multiple confluent vertical artifacts, no suspicious of cardiogenic pulmonary edema, may be associated with the peripheral parenchymal lesions. In the lower part of this slide, you can see in visualization diaphragm excursion, right subcostal view in M mode, normal diaphragm excursion, and no diaphragm excursion in low part. This slide when patient has diaphragm paralysis. That's why here you can exactly see that there are different patterns for ultrasonography data for other visualization methods which help for diagnosing origin of acute dyspnea, because if summarizing, acute dyspnea can be in cardiac origin in such disease like acute coronary syndrome, cardiogenic pulmonary edema, pericardial effusion, pericardial tamponade. It can be in case of pulmonary origin diseases as a pneumothorax, tension pneumothorax, pleural effusion, pneumonia, pulmonary embolism, asthma exacerbation, COPD exacerbation. And about management, generally, of course, we should treat disease which leads to symptom of acute dyspnea. And acute dyspnea typically is due to a more life-threatening process and required rapid emergency intervention. All patients should be placed on supplemental oxygen, pulse oximetry, cardiac monitor. The appropriate treatment should be initiated based on the suspected or diagnosed etiology of acute dyspnea. If respiratory failure is imminent, there should be a lowest report for intubation patient. And diagnostic workup should be performed only once appropriate and the patient is stable. And key messages about from this lecture that acute dyspnea is an umbrella term and may be primary manifestation of respiratory, cardiac, neuromuscular, psychogenic, systemic diseases or combination of this one. Lung ultrasound and echocardiography are the first rapid and non-invasive line of assessment that differentiates heart, lung, extrapulmonary involvement in patient with dyspnea. Non-invasive respiratory support modalities such as high-flow nasal oxygen and continuous positive air pressure used for treatment patient with dyspnea requiring ventilatory support. Thank you for your attention.